session of day 3, which concludes our conference, which has been 3 days full of excitement, which we have enjoyed virtually and some physically. We have shared experiences. There are some lessons learned, plenty of them, on how to improve our healthcare delivery system out there. So, as we conclude this conference, permit me welcome some of the panelists who have just joined us, but of course the session chair will do the needful to introduce them accordingly. But as a program director, I can't just keep quiet. I want to welcome Professor Freddie Sengoba. Our teacher, you are most welcome, but you will be appropriately welcome. But I also recognize the presence of Dr. Sarah JICA, our Commissioner for Planning, Policy and Finance, and of course other panelists whom I will leave the session chair to really introduce appropriately. Ladies and gentlemen, without much ado, I'm going to invite Dr. Martin Sendiona, who is Assistant Commissioner, who will be the session chair for this closing ceremony, and he will be taking us in all the deliberations of this session. Our online delegates were only now in Bunyonyi Hall for the closing, so the other Aswa and Kafu have been closed. So ladies and gentlemen, let's join our hands to welcome Dr. Martin Sendiona, the session chair for this closing ceremony. And to you delegates, you are most welcome, and thank you for your participation. As it comes to the podium, I want to thank Lane Productions, who have been our IT experts who have really done a good job. Let's give them a round of applause, because we have not experienced any itches here and there. In terms of the sound system, connectivity, and so forth. So it has been awesome working with you, and keep up the standards. Over to you, to Dr. Martin Sendiona.
Thank you very much, Table, our master of ceremony for this conference. Ladies and gentlemen, I want to welcome you back from lunch, and thank you so much for being with us in this conference all these 3 days and your active participation. We are going for a panel discussion, as the predecessors communicated. We have 1, 2, 3, 4, 5 discussants with us. 2 are here physically, and I would like to welcome them to the front here. We have Dr. Sarah JICA, has been introduced already. We know her. Doctor, you can come and sit here at the front. And also we have Professor Freddie Sengoba, who is also very familiar to us. Professor, you're welcome to sit at the front. Then online we have 3 personalities, distinguished personalities who are going to be joining us online. We have Dr. Dithan Chiraga, and who is the chief of party for Right Search North. And also we have Dr. Margaret, Dr. Sentumbwe. She's also going to be joining us online. And also from UNICEF, we have Dr. Grace. She is also ready to be with us. The discussion we are going to have is as you see in their program, is about the client-centered quality of care to ensure patient and health service provider safety through evidence-based practice, which is our theme. So the discussion is going to be rotating around the theme. And each panelist has 10 minutes to give a brief overview on the topic assigned for discussion. Then we shall have a moment of interaction, and we see how we can learn from one another during this time of the conference. So first and foremost, I would like to invite Dr. Sarah Biachika. First of all, thank you so much, Commissioner, to find time to be with us this afternoon, and also, of course, for the lot of good work you are doing at the Ministry of Health. The people here and out online will be interested to know and learn at this moment what is the influence of result-based financing mechanism on enhancing client-centered quality of care in this country. You can share with us your experience and expertise in 10 minutes. Doctor, you're welcome.
And good afternoon to you all, colleagues. And my task is, as mentioned, to share with you the influence of the RBF mechanism on enhancing client-centered quality of care in Uganda. I'll base on our experience largely under the AMCHIP project, but also as far as the country is concerned, you are all aware over the last 2 years, we are rolling out RBF from pilot mode to a national scale-up in a bid to institutionalize the results-based financing care. So as I talk now, all districts in the country, using a phased manner, are implementing RBF based on the national RBF framework. And largely it is spearheaded by Ministry of Health under the RBF unit. We also have a few districts in northern Uganda where Enable continues to support with funding from the US government. The focus of the RBF was largely on primary health care services. So we started with focus on health center 3s and 4s, but later on, hospitals were brought on board, largely for the continuation of the referral system, because the program is focused largely on reproductive, maternal, neonatal, and child health services, and aiming at reducing morbidity and mortality. So as you know, maternal mortality and neonatal mortality or child mortality still to be reduced. We need some of the services of secondary level care or tertiary level. So the general hospitals, referral hospitals are also included in the RBF program. You can go to the next slide if you want to. So largely, as I mentioned, it is focusing on primary care facilities, and we have of the first 1,317 implementing, 81% health center 3s, then 14% health center 4s, and the hospitals are only 5%. And it is both for the public and private, largely PNFP sector, and focusing on those facilities that are receiving the primary health care grant. So why RBF? First of all, one of the reasons why we embarked on a national scale-up is because of the dissatisfaction with the services, especially based on the huge financing gaps, but also the traditional mechanism of input-based funding was found to be too centralized, and the health workers or health managers had no flexibility in terms of planning, programming, and allocation of resources because the funding was tagged to certain budget items. The RBF approach, as we all know, promotes more autonomy, independence, and management with improved service delivery and hence outcomes, better outcomes. And that's where the client-centeredness comes in terms of the users of the services. And also, we've noticed there's been increasing interest on improving health service delivery in line with management reforms and accountability to the patients and communities. The RBF mechanism emphasizes involvement of patients and getting feedback from the patients as well. So specifically for this conference, we've gone through a process of RBF implementation, but for ensuring client-centeredness and quality of services, it is largely in the last steps of the process, which is ongoing. That is delivery of a defined package of care, which with indicators that are really show that you are focusing on the client. That is both the outputs in terms of numbers, but also the quality aspect, because you have to assess the quality of the services conducted. And the assessment is through quarterly RBF verifications by the district health management teams, but we also undertake independent external verification by an independent agency that goes every 6 months and validates samples a number of districts and facilities to validate the RBF program implementation. We have tools that were developed, and the quality assessment tool has 9 modules across the health systems building blocks, but our interest here largely is on module 8, which is client-centered care and safety, but also module 9, clinical management, because it looks at whether patients are being managed according to the guidelines, and so it has that component as well of client-centeredness. You can see that in terms of weighting these standards, client-centeredness is weighted highly also from, clinical management is weighted at 30%, and client-centeredness comes next at 15%, with the medicines, which you all know are a major input. So that shows that under the RBF program, client-centeredness or quality in terms of the users of the services is very important. So on a quarterly basis, we do assess these indicators. And what have we observed? On the right, my left, you can see the results for the health center 3s during both, as I said, we implemented in phases, phase 1 and phase 2. But in summary, we find that if you look at the blue bar and the gray bar for health center 3s, you see that at the time the program was starting, the client-centeredness module scored only 77% in the first quarter of assessment. And for phase 1 districts, we have so far done 6 quarterly assessments, and in the last quarter, quarter 4 financial year 2019-20, the scores had increased to 86%. It is worth noting that even in previous RBF programs which were implemented through Enable, there is a kind of a plateauing at a certain stage in terms of both quality and quantity outputs for programs. And when that plateau comes in, it means then that there are certain bottlenecks, certain challenges that require detailed analysis and focus so that you can be able to achieve further. So we are now at a kind of a plateau, and we now need to unpack those bottlenecks and see what next we need to do to address the aspects in client-centeredness. These are just the standards that we assess. Do they have an outreach program, client feedback mechanism, preventive risk and patient safety programs in place. We address issues of infection prevention and control, waste management, reporting mechanism for adverse events, and also occupational health and safety program. All these standards are drawn from the Ministry of Health Service Delivery standards. And that is the progression in the client-centered module. As you can see, it is at saturation close to 90%. And from the analysis, the critical gaps we are seeing, why there is that plateauing, are largely due to gaps in waste management, especially final waste disposal. And that requires the ministry to see how we can invest better to ensure that this waste, whether we have incinerators at the facilities or have a mechanism of collecting this medical waste and have it, because it's beyond the capacity of the health facilities. Then the issue of establishment of a reporting system for adverse events is something that probably is not a culture, that we need to build capacity so that people can now be able to document whether there are any of these harmful errors, whether they are there or not, because once you have not documented it, you cannot know, is it a problem or not? So that is an area that we need to analyze further and make sure it is implemented. As I conclude, I would like to say that I mentioned an external verification agent in place, and as the health facility providers, we found that if they did do client assessments themselves, it may cause bias. So it is the external verification agency which goes out and interacts with the community to get their feedback outside of the health facility environment on their perception of the health services. And they do sample different facilities. So I just picked the last two reports, the one of August 2019 and June 2020. And what you can see, the blue is the 2019 report, 6 months report, and the June is the orange or brown is the current report, which shows that actually there has been improvement in the perception or in the client satisfaction as indicators for all these, for the facilities that are implementing RBF. Where we are really still lagging behind largely is in aspects of general health facility, hygiene, and accessibility in terms of time patients take to get to a health facility. Otherwise, all across the board, as you can see, there is improvement in client satisfaction. So in conclusion, additional resources drawn from the RBF and the quarterly verification process have enabled health facilities to address the quality gaps, especially under client-centered care. And community feedback mechanisms have shown there is improvement in client satisfaction with the services provided at these RBF facilities. And what we are working on is how we can further institutionalize the RBF approach beyond the RIMNCH program or package, using affordable and sustainable implementation mechanisms. Thank you.
Thank you very much. Thank you very much, Dr. Sarah. The information you have shared with us is very important. We've been here, and the issue of resources has been highlighted as one of the areas that we need to look into to improve our performance. And we're also happy to hear that all the districts are covered. The issue of patient involvement, when we talk about client-centeredness, then the involvement of the actors becomes very, very important. And you mentioned the tools. We are on the first day of this conference. Our HFQAP has facility quality assessment program tool. A revised version was launched. And so we appreciate when we mentioned it. The tool as of course one of the key the key parameters you need to get RBF fully operational. So thank you so much. We are going to have a time to discuss as you capture your points, write them down. We shall get time to have the discussion briefly. Next year, we are going to welcome Professor Freddy Sengova. He's part of us in many ways. Attends our technical working groups as a member of the HIPAC and top management, and of course, he's from the academia. He's going to give us another perspective, focusing the role of leadership in ensuring quality services delivery. Professor, you're welcome. We have about 10 minutes to summarize some of those points.
Remove the mask so I can speak freely. Thank you, Chair. Thank you, co-panelists, Director of Planning, Dr. Sarah. Ladies and gentlemen, you're welcome. I first of all want to thank you for inviting me to present on this important topic. I think the topic was exciting that I decided to come in person. Otherwise, I was going to be online. But I thought it would be nice to actually come and share with you. And in that regard, I don't have slides, but I think after lunch, sometimes you need some stories to keep you awake. So I'm using the non-slide approach, going back to the roots. But on a serious note, I think the topic addresses many fundamental issues that we need to be reflecting on, particularly at this point in time, partly because we are writing a new sector plan, partly because we are being launched, partly because we are battling epidemics, partly because we are trying to see how can we remain relevant, especially in the communities providing services of good quality. So the topic about quality, safety, and the leadership in that, but also the focus on providers, clients are very timely. If I had to revise anything, Chair, I would have added the community. So in my discussion, don't be surprised if I do stretch it a bit, so that we also look at the community. As you heard from the keynote address this morning, it is definitely important to orient ourselves around the patient and the provider, but sometimes there are more people out there who are not yet patients, but they still need quality services. And it is that will support or prevent them from turning into or becoming patients. They also need to be at the center of our planning and our delivery. So what is the problem? The way I've characterized this from the discussions that have been already ongoing, I've listened in yesterday and a bit today. So broadly, we still have some dissatisfaction of services out there in terms of service gaps. These may be, like from the assessments, we can see gaps that are not yet being met. Just like Dr. Sarah also indicated, we have sometimes reached a plateau and we need now to break through with the new ways of understanding bottlenecks. We know that part of the solution is always resources. Resource, not only money, but money is very central. We need to have more of these to try to overcome some of the constraints which require money. But there are also resources that don't require money that are central to this leadership challenge. The number of health workers we have, how have they been deployed to cover the ground, the support systems that they need. And I always want to call this the front office and the back office. I think sometimes the front office receives a lot of assessment. And over the years, I think one thing that I've learned, which I very much now want, hopefully, to advocate for, is how do we also assess the back office more and more? Because many times, the constraints we see in the front office, some of you, when I say front office, you know that it's like shops. There is where the people interact with the clients and sell the goods, but the decisions are made at the back office to procure, to make decisions on which goods to stock, which ones to reduce. Those things are sometimes made by other players in the back office, And if those players are making decisions, those decisions will be reflected in what we see in the front office. The assessments we have, most studies we see, is how are patients interacting with their providers and what the gaps there. Many times we don't ask, let's see the systems that support these guys. How are they organizing themselves? Because if we don't understand those interdependencies, it's like a war. If you have your troops out there in the field, you also want to figure out, are they being fed? Are the commanders sending the right ammunition? If they need air cover, is it coming at the right time? If there are tankers they need. Otherwise, if you just look at these guys shooting with their small AK-47, you may not get the entire architecture of how to win the war. And I think we need to start going a bit higher and higher to see where the generals sit. Also to see, maybe there are constraints there we need to work on. And in my talk, I'm going to try and see how leadership around the front line can be also looked at in combination with leadership in the what we'll call the meso or the middle area, and then on the top. Because if we are able to do all the up and down and the middle, then chances are we'll be able to overcome the quality challenges. Because leadership at the front line may not be sufficient, leadership at the top may not be sufficient. We also need to understand the interaction. And if I fail and chair stops me at least midway, the point is this that I want to make today, that there is a lot of interdependence in solving quality and safety issues. The workers on the ground interdepend very much with the policymakers and the policies they send, the tools they send. They also interdepend very much with those suppliers and the quality of products they receive. They also interdepend very much with the deployment policies and those who deploy people and train them. They interdepend very much what communities choose to do or not to do. I think right now the communities have chosen not to follow COVID guidelines, and we can see what the quality and safety issues that we are having. And that is partly the interdependence we have with the community and the health system. You can't just say you have a quality committee, therefore it is going to work when the community is exposing themselves and becoming very sick. So we also need leadership the other side. We need leadership within the front line. We need leadership in the back office. We need leadership all the way up. And that the interdependence we need to manage. That requires that we organize our leadership capacity systems differently. This is the point or bottom line. How do we ensure that we actually create distributed leadership so that at every point we are sure they are leaders? If it is a head nurse in a team, there is leadership at that level we want. If it is a committee in the hospital which is addressing quality improvement, there is leadership there. If you are the cleaning department of the hospital, there is leadership we need there. If those people pour soap and didn't warn people that this place is wet, you may get fractures of your patients and your workers. That is the safety issue we are talking about. So you can't even exclude the cleaning department, the laundry department. So sometimes when we talk of quality leadership and whatever, there is the assumption that we are talking about position leaders like my colleague here, or the director, or we are talking of the hospital team or the quality assurance. But unless we have leadership at all levels, and then those leadership have leaders for them, in other words, you have leaders of leaders, that's how we can get the whole system to work. So I'm talking about what is called these days distributed leadership. And how do we build this in the system is what I'm going to spend the next couple of minutes. So clearly what we have done is a lot. We have in particular done a lot of surveys about quality, about safety, and recently we also started doing things around violence. Was it, what is the survey that was, it was something to do with not domestic violence this time, but health worker violence, something like that. I forget in SMEA working group, 2 years ago, there was a nice survey that was done, which I have now forgotten. But we are also trying to say health workers may themselves be at risk, either by the patients or by themselves, and those of you who have worked in these hospitals, you can also understand it is an industry full of women and a few men, and sometimes that also creates its dynamic. So some people may not come to work because they fear harassment. There is a guy there who is disturbing them. And that might make the whole performance not to improve. And there are risks to them that might be important to manage. The other issue that we've done very well is also we formed committees, we've trained, we've had many health systems intervention in this country. We've trained managers, we've trained structures of leadership, including the district health teams, HUMICs, or the human, facility management committees. But we've had so many trainings going all the way to universities, degrees in management, and that I think is a very, very good resource base on which to train. There are also, to build capacity. We also have technical working groups. These are leadership forums and structures. And they may not all work well, but I know those concerned with quality, research, information have been probably the most outstanding. Maybe because the one I attend, but I know that those are doing very well. And my colleague here has been very active in them. So we have actually a critical set of what it takes to actually build leadership for quality and safety. But there is something that we also need to start thinking about, as I just said. Clearly, we need to see that the guidelines we send down allow many players to come and be part of this game. Because as recently we were in Entebbe with when we are going through the documents with the SCAP team there to look at the framework for quality improvement and supervision. And I made also this point that it's very important to have this committee, but still you are going to have several other quality improvement initiatives within these settings. Because if I am in OPD, I'm as head of OPD, so we have a problem of crowding here. How do we solve it? And as a department, we may have a small quality improvement initiative at a micro level. It might refer back to the committee, it might then go back to the center. And I'm happy to see that many of these quality improvement initiatives have been presented today. And for me, that is a very powerful evidence that a lot is happening. And many are being presented by our colleagues in the district leaders, senior nurses in facility, and I think this is very great. So we have many of these being done, but I think what we need to do is to address the issue of interdependence. What am I talking about, interdependence? We've been working with my colleague here, Sendiona, and team in the ministry in about 9 districts to try and help them and become more skillful in diagnosing management problems, but also designing management solutions. Sister here from Ruero will tell you is one of the districts we are working with, the Ruero team. We also have Nakaseke and Wakiso. In the west, we've been working with Kabarole and Toroko, and what is the other district there that I'm going to forget? And in the east, we have Buyukwe, Jinja, and Ruka. So what we've been doing when we sit with the district health team is to figure out, okay, you are doing all other things well, but when it comes to management of a district, what are the issues? And then they start thinking about the management challenges they have. What is interesting and which I want to let you know, and this is probably partly our problem, the way we've trained people, they quickly say that problem has no indicators. We can't measure it. So let's leave that aside. Let's go with the one where there are indicators. But the problems they are living that don't have indicators are the problems of human beings. People are not showing up. The conflicts or the interactions which are not working, the support system. So they just leave those behind because for some reason they are not measurable. And this is one thing that I wish we could collect yesterday, because clearly a lot of management works with the impressions, meetings, interactions. Many of us when you grow up and become a manager, you attend meetings, and some people complain, but I've spent a whole day in meetings, because they don't know how to count the work in meetings. You may have actually solved many problems by being in meetings, but because there is no something that you can put there and say, I've done this, we underestimate. And why am I talking about this? Because leadership works very much with those soft things like meetings. What is the problem? Can we sit down and digest it? But people will say, oh, we've spent a whole day in meetings, we are trying to understand the problem. That's time wasted. Now, that is the failure of leadership. You are beginning to fail on your leadership course because you actually don't see the time you are investing in coordinating, in solving problems as part and parcel. So, as I come to a close, we need to bring together many players in quality improvement. What I've learned from those districts, when we are talking about health workers not showing up for duty, we had a lot of interest when we realized that, oh, we need the human resource people to be in the room, and they came and told us the human resource issue. They brought all the guidelines from public service. They started training each other on how do you actually make appraisals. How do you even plan appraisal? Because appraisal, you don't call people, come, I appraise you. You start a year before to plan that this is what you are going to be delivering this year. These are the standards, these are the targets. So now, over time, let's see how you are doing, and time comes after a year and say, now come and we appraise. When you go out there, people even don't know who should appraise them. And I've been impressed by the confusion there, because some doctors are appraised by these parish chiefs. Are they parish chiefs? Or no, sub-county chiefs. But when you ask a sub-county chief, so what does a doctor do on a day-to-day basis? They don't know. They say they get PHC. Because they get PHC money, I have to appraise them. But the principle of appraisal, you are all lost. You basically don't know what this guy is doing. But because he receives PHC, then he becomes the general person to appraise them. There is so many confusion there. When people get annoyed, say, Fred, you've annoyed me, now come for appraisal. So it's like that. So in a sense, what I'm saying that even those tools that should help us, the partnership we need, I think the point I'm trying to make. At the district, we can actually tap into other players to solve our management and leadership and quality issues. And the more we realize that at that level, there are actually players that can solve problems that will help. We also need system-wide efforts. And here is where we need to start thinking. We are solving a problem here. Where do we stop? And you've heard, for example, if you've hit a bottleneck now at that level as a team, who is the one to help you to move to the next level? Maybe at that point you really need to engage outsiders who can come and say, you know what, maybe we can give you some more people here, we can renovate that space, or we can bring this kind of supply. Then you can overcome that and now become operating at a higher level. And the stakeholders are many in the health sector. And when you're a leader and you have many stakeholders, it is also incumbent on you to coordinate them. Government itself is doing its part, and when you read their report, there are always those concerns. The stakeholders are quite a number, and it costs money, of course, to bring them on the table, to meet with them, ensure everybody gets their thing. But if you are in leadership position, you need those costs to be spent to ensure that everyone is following the common goal. And that is very important. So in the end, as I try to wind up on this, these interdependencies are important. We need to realize that positional leaders, if you have been like the chief executive or the chief nurse or director, planning or administration, those are important positions to support quality improvement, to support safety improvements for health workers and for clients, and to see that what we do actually do bring about the satisfaction of all of those communities. But also we needed to ensure that we go to look at other leaders that play an important role in what we do. If they are suppliers, and it requires us to talk to our supply chain leadership, then we should be able to mobilize them. If it is people are recruiting health workers, training them, or for some reason taking them away for training, they should also be part of the table. If it is communities and the communities need to do something among themselves, we should bring community leaders also to be there. Because many times even the way resources are used in the facility is because maybe leaders in the community would have done something more there if only they were able to be engaged. So I'm talking about how do we engage beyond the positional leaders that we have in mind? How do we engage all the players that have influence in what we do? We need to understand that quality and safety is outcomes that are contributed to by very many players, and sometimes they may be as small as cleaners, as I said, but they can have a big influence. In the UK, for example, there were a lot of falls where elderly people were falling from the beds and getting injured while in hospital. It turned out that it was an engineering problem for these beds. Sometimes people, when they sleep, they turn around, and if the bed doesn't have something to hold you, you find you are falling on the floor. So they had now to go back to the whole engineering problem, bring engineers to understand. If it is cleaners and things are getting contaminated, you also need to bring them on board. So as I end, let's be leaders of coalitions. Let's manage alliances. Let's try to understand the stakeholders that we need to bring together, both up, down, and the middle. And let's be leaders of leaders, or let's cultivate leaders at the ground and those who are going to help lead them. It is like a choir. Some of you know jazz. I don't know if everybody listens to jazz, but I'm one of those who loves jazz. You know, jazz, there is only what you call like a backbone tune, which goes, but other players keep filling in as they, You find somebody has just put in a note, another one, the rest of the band gets to know that if I add this one, it will enrich. If I add, so there is a minimal tone which goes through. The rest is, you need to work with people who know what to add to make value and improve the product. And I think that's where we are. As I end, Chair, I think COVID is here, and safety issues have become very important. And as you know, I also chair some hospitals, so I'm also borrowing from there. So if you don't know, you may think you are doing a good job in the hospital, or not realize oxygen is run out. Then you start looking at who manufactures the oxygen. Then you start running around to the manufacturers. Then they tell you, oh, there is this thing called cylinders. We don't have enough of them. So before you know it, you are in a very different territory, just because the game has changed. Now the game is, safety is around things like oxygen. I had never managed or understood the supply chain, but now it's the key thing. It's the most medicine for COVID. But we needed to manage that for health workers, for the community, and for everyone. So thank you for listening to me. I think let's try to improve that formal and informal power and leadership for quality and safety.
Thank you very much. Thank you very much, Professor, for really giving that information, critical information on leadership in our quality improvement framework. It is one of the key first objective, actually, to strengthen leadership and management in our institutions, and also identifying the actors. I think one of the areas we are still struggling to strengthen. Even when you look at our hospitals, the in charge of the ward, look at the role of the specialist in the regional referral hospital vis-a-vis the in charge of a particular ward, and so on and so forth. You find that there are areas which we need to really appreciate. The committees, we have them so much in quality improvement. They are there, and I think the leadership function becomes very critical. So we shall again have time to discuss. Professor, we appreciate. Let us now go to the other contributions we are going to get from online participants, and we shall start with the WHO. And Dr. Olive Sentumbo is online. Doctor, you are welcome. We are going to talk about what it is going to take to provide quality support supervision in the healthcare service delivery system, what it will require. You know, WHO is one of our advisors. They guide us in many of the areas of system performance. So at this moment, ladies and gentlemen, allow me to invite Dr. Olive. I understand she's online already. Dr. Olive, are you there?
Hello.
Hello.
Good. I am on.
Very good. Doctor, you have 10 minutes. This time I'll be very strict on time. Since we are getting late and we need to close this conference. So when you hear a knock on the glass, then you'll notice 2 minutes to time. But otherwise, you're welcome, Doc. Go ahead and share your views.
Okay, thank you very much. And I would start by thanking you all for making this possible this afternoon, that we are able to look again at providing quality support supervision. And of course, because I've known mainly Ops and Gain for the last 30 years or more, most of my examples will be around that. And first of all, and I'm very glad that I've spoken after Professor Sengova, most of my things almost follow in line. If you're going to ensure that you're doing support supervision, then you must understand who is it that you are targeting this support supervision. Who is the person? So you must understand what is allowed for them, and that is the scope of practice per provider, cadre, which you're going to manage. And definitely put into consideration what would be the most innovative capacity building approaches that may suit this particular group of people, because who are they? What time do they have? And therefore develop systems and guidelines that suit their mentoring or coaching, which you're going to do. But very important, as we get out from our seats to say we are going to supervise and mentor people, we must be knowledgeable about the particular subject we are going to be dealing with. And we must be skilled, because looking around most of the ongoing meetings now, ongoing interactions with health workers, most of the gaps they are finding, which make it difficult for them to do their work, is that they lack a particular skill, a particular competence somewhere, and they cannot progress very well. So they would like to ensure that those people who go to supervise them can add knowledge, can add a skill. And when you are setting out to supervise, even before you reach there, make sure that the intended group or team knows the objectives of that supervision. Why have you come? And please ensure that you organize your work in chunks. Sometimes we do too much and finally leave the mentees wondering where exactly are we, because they don't get to understand where they should have stopped and how it began and which skills they were supposed to pick. When you get into an environment where you're supervising, please look at the local environment that is applying. Because at different levels of care, things are not exactly the same. And yet sometimes we have to do particular interventions at almost 3 levels, but using slightly different environments. So study the environment, see what they have, and then do a job that suits what they have, but not losing the skill that you're supposed to provide. And I think it's important for us all to understand that if you're going to supervise, if you're going to mentor people, you need to put aside time. just agree that this much time I've reserved to make sure that I mentor these people, I supervise them, and I'm not putting their other tasks. Or else when you're doing any kind of supervision, please use very clear mentorship tools in relation to the subject you're addressing. I have seen that in our area, RMNCH, some of the supervision tools are there but not systematically used. And yet, you really need to take it stepwise. This is step 1, this is step 2, this is step 3. And when you don't have a clear mentorship tool to support you, even the supervisor, may do step 3 instead of 2. And it's going to be important that you are knowledgeable around quality improvement concepts and approaches, because people are addressing gaps and they have to know how to even identify those gaps and how to fill the gaps. So you will be expected to have that kind of knowledge and be able to pass it on to the mentees. And therefore the leadership skills, which Professor Sengoba talked about, and it's going to be important that in whatever you want to pass on, you are basing it on a particular set of elements of that skill you are trying to teach. And so being objective in what you are trying to pass on. If a person did step 1, 2, 3 and skipped 4 and 5 and then went to 6, you will have to point out in a nice way and see how you go back to ensure that you are stepwisely demonstrating the skill that you want them to pass on or them to have. Very important, and very quickly, therefore, you need to ensure that the people you are coaching, supervising, are using data. That when I do ABCD, these were the results I got. But when I improved and did this as you said, we seem to be getting better results. It's very important because data which is improving encourages people and they are willing to take on another skill when you return. It's important to agree with those trainees on a particular schedule which you're going to use, because this is a continuous process. You agree on what you're going to achieve and when, and establish those working teams at the facility level, which will be staying behind to work with each other, to improve each other's skill, and to keep revising on the skill which you went through this week. But I think it is also going to be very important for us supervisors to understand that we also as supervisors need to work in teams to ensure that we are maximally learning and mixing skills. Because you may be very good, for instance, at taking through students in regard to a pantograph, but your colleague may be better in demonstrating how to do an episiotomy and how to repair it. You may not be an all-time rounder, and even when you're all-time, somebody may be better, slightly better. You are both at the same level as supervisors, but if you pick that your colleague is slightly better at this, it would be nice for them to demonstrate if you're in the same team, and you never know, you can also begin to perform like them. It is going to be important for you to develop a post-supervision action plan by consensus with those supervisees so that they know what comes next and who is responsible for what in order to sustain that skill which you have provided that day. You must encourage them to continue to monitor themselves as they stay behind and even do some implementation research on what works very well. When we do it like this, does it work out? What about if we slightly do this? What happens? So that they develop those approaches which allow them to keep improving based on what they keep learning. But this work of a single supervisor or two supervisors in a team in a health facility need to work together with the district level. There are some areas of work which we do across different cadres. And sometimes when we go as clinical supervisors, we may not get in touch with particular groups like community health workers. You need to make sure that the district has an established system which links the work you are doing in the health facility in relation to particular skill to what the community responsibilities are. In the case of RMNCH, there are a lot of things we've given to community health workers, VHTs in particular, and some peer providers. So do we exactly do the same things, and does the flow of skills actually reach to the community health worker? And as a district, they are responsible to make sure that they are the capacity to supervise all those levels. As a district also, they are supposed to make sure that they are supporting the health facilities in which the clinical mentorships are being done, not to have stockouts. As districts, they are also supposed to take care of instruction needs of health facilities, because certain skills can only be best performed in a particular infrastructure. Especially for you people who work in RMNCH, you know how privacy, confidentiality, space, water is required. So you have to work across teams and across levels. The district has also to show that it is using data and it is working in between health facilities. It should be able to communicate when it comes down to the health facilities to say, after this mentorship, we seem to see your ANC4 is catching up. You are doing very well. So that they keep the health workers motivated that they've gone through this particular mentorship, and it seems to be resulting into data differences. It is also going to be important, as we said, as we heard from Professor Sengova, that we harmonize and coordinate partners who are supporting the district. If you have 3, 4, 5 IPs, are you making sure that they all support how to monitor labor, how to make sure that they all know about magnesium sulfate and how to administer it and how to monitor it? Because when we are more and doing the same thing and re-emphasizing it and repeating it, we get better results and more of us know. And it encourages more learning facilities across facilities, because different partners support very different facilities. So the scale up will be easier than if you're working along with fewer partners who are not coordinated.
Doctor, I need to conclude.
When you get down to that,
Hello?
I think I'm ending.
Oh,
Hello?
you need to conclude.
Hello?
Think.
Yes. So we are ending up by making sure that also the things that you have taught, that you have mentored people in at the health facility are taken care of. You cannot do particular skills, for instance, without making sure that water is running. You cannot do particular things if you are not assessing the client satisfaction to know what they think about the service you are giving. For you, you may be proficient, but the way you give it, it is the client satisfaction assessment that will inform you that you finally made it. You've achieved the skill and your client is satisfied. You have to do community engagement, and you must strengthen the links between the health workers who you are mentoring skills in and supervising to the community, which is the recipient, the beneficiary of the service that you are giving. Finally, a good supervisor really as an individual should have very good written and verbal communication skills in order to do all those things we've mentioned above. But in order for you to be working with this group of human resource teams that are also human, You must be empathetic and compassionate about their feelings and needs. You should be able to do conflict resolution in these health facilities where you go. Some things are not moving well, not because they are completely not skilled or knowledgeable, but because there's a lot of conflict in between the different levels of the health workers. But you must also be able to delegate, because health workers all over, or workers anywhere, need to feel valued, and they need to feel that they also can contribute to that quality improvement which you're going to do, which you hope for. What is their own role? So delegate them. This time you do this, I want to find ABCD done by you. Make sure you can support problem solving. Make sure you encourage time management. And very important, be confident. Be hands-on and confident in your hands-on. And lastly, please be approachable and considerate. Then when people tell you that here we are only able to start ANC at 10 because the women start with their gardens, understand that it's not there, but the community is slightly different. And that is why they are doing it differently. I want to thank you, colleagues, for giving us this opportunity to put this together and share with you. Thank you very much, and over to you, Chair.
Thank you. Thank you very much, Dr. Olive. Sorry for cutting you short. I'm sure you had much more to share with us, but we appreciate what you have been able to give us this afternoon, support supervision and quality of care. And colleagues, members in this conference, we need to appreciate that WHO has been very supportive in this process, including the review and development of the new support supervision strategy. They give us the initial input, and we appreciate that. And of course, we continue to work with WHO throughout in the different areas. Supervision is with us, very important. Sometimes we don't give it enough attention when it is such an important element in improving quality of care. Without wasting any more time, I want to call upon Grace from UNICEF. UNICEF have been very much involved in the quality of care for maternal and newborn child health care services, especially in West Nile and also in Karamoja regions. Grace, you have only 10 minutes. Kindly give us one of the highlights, very brief highlights, so that you can have time to discuss. Grace, are you online? Are you there?
Thank you so much, Dr. Sendion, and thank you so much, panelists. I'll quickly run through what we have done in West Nile to improve quality of care. The slides might seem many, but I'm just going to speak through them quickly. My presentation is on improving quality of care, looking at MNH services. I'll basically look at the scope, objectives, approaches, and key asks, and I think this is an important area that we'll need to focus on. So the program in West Nile, I'll focus on West Nile, but our program goes beyond West Nile. In all our districts where we have UNICEF-supported programs, we try to replicate what we are doing in a region such as West Nile. So our MNH program looks at improving quality of care for maternal health, improving governance, improving physical environment, which also lies under quality of care, and also improving utilization of services. So we hope that while we have addressed all the above, the service utilization should go up. This slide basically shows the approach that is used by UNICEF. It's a health system strengthening approach in which our health program is anchored. So I will not go into it because we have discussed in details the different building blocks, and this is what informs our program. Now, moving down to quality of care, we have used our quality of care program has been informed by the different tools, the HFQAP, the quality of care assessment tools that looks at the standards of care, the 8 standards of care. We have used the client satisfaction survey, and then we have also used the progression model that assesses the building blocks, how the different districts and stakeholders are actually progressing from one level to the other, and which should all contribute to the work that we see. At district level, at district level, we are trying to work with the district leadership to strengthen governance. And here we have supported data quality assessments. We've supported the districts to hold quarterly performance review meetings. And at the facility levels, we've supported the midwifery quarterly review meetings. And these are learning meetings for quality improvement, where they come together and share their learnings and the change packages that they have tested in their units. Here, this slide basically shows some of the work achievements at the district level. And as you can see from the pictures, the districts reviewing their performance. I will not go through that. So let me go to the next, which is basically quality improvement. I'm mindful of time, so I'm just going to run through quickly. So in quality improvement, our aim has been to ensure that the facilities, even before the RBF was rolled out to all the regions, we were aiming at ensuring that all our facilities that we support actually qualify by providing inputs in the different areas. And that is the more reason why we use the HF-QAP. And through the HF-QAP, we were able to address some of the bottlenecks that would see these facilities qualify. And then the quality of care assessment tool, looking at the standards, would actually point us into where exactly we would put our resources. And for UNICEF, we said that for a facility to qualify as a facility implementing quality of care standards, we should look at all the 8 standards of care. So even when it came to the health center FOS, we also looked at functionalizing, this is in West Nile, functionalizing the health center FOS. We looked at areas around human resources where we provided surge staff. This is a short-term project-supported staff where we provide salaries for critical staff like anesthetists, the doctors, medical doctors, and mainly the midwives, so that they can run these facilities. Then we also supported hands-on clinical skills, surgical skills, using a team of specialists that would go and camp in these hospitals and bring together medical clinical staff from the health center FOS and other hospitals for 1 week, and they work together in the routine care. And we also supported the equipment, lighting, and blood drives in the region, because blood was quite a critical issue. So in order for you to address quality, there's no blood, a health worker or a medical officer is frustrated and they cannot do much. And we also looked at the WASH. So the whole package, ensuring that the WASH was addressing the needs. So the assessment for WASH also happened, and each facility was addressed according to the gaps that we saw. And then respectful care, we focus mainly on maternity units, where we are saying that we need to enhance the environment, not only for the mothers, but to ensure that the health workers are motivated to work in a clean, organized environment that has water, a washroom for the mothers, which would motivate them to deliver their services. And when you look at these pictures, some of the pictures on the things that we have done, procurement of equipment. Now, in the procurement of equipment, we did not only end at that, but we worked with the regional referral hospital, the regional referral hospital workshop, to ensure that there is an assessment on the equipment that is available, update of the inventory, and the repairs of the broken equipment. Because our findings were that, or even as we deliver, and other partners, we deliver equipment, they sit in the stores, they are not used, and therefore a team of biomedical engineers working together with the regional workshop, these are volunteers. We use them to traverse the whole region, assess the needs, train on end user, and now they are going back to fix the broken equipment. I talked about the refurbishments. We are working on 17 out of 30 facilities in the region. We've provided ambulances and also provided fuel for interfacility transportation, and in some cases also maintenance, which we ideally should be the work of the facility and the district. And then I talked about the WASH. This picture shows an example of the surgical skills training that we supported over the last 1 year. So on a quarterly basis, this team goes out and works together with the clinical staff, especially at health center FOS and hospital, because we realized that most of the mortalities and the deaths were happening in the hospital because of lack of the supervision of the doctors, and then lack of continuous CMEs and mentorship. And therefore we thought that getting them more qualified teams of consultants who would go work with them. These are our own staff, but in different regions, bringing them together to work in these units would help to enhance their skills. So in addition to this, we also did trainings on basic emergency obstetric care. And for the surge staff that we supported, we also followed up on their recruitment. For example, in Koboko was able to absorb 11 of their staff that were on whose salaries we were paying, which was a good sign of commitment. This is some of the quality improvement projects. Some of our projects actually qualified, and some of the facilities were able to present the good works that we are doing, where we have district mentors going out to the facility, working with facility QI staff on the different projects and assessing their performance. I'll not go through it. So ensuring during the COVID period, we also continued to do the mentorship. On your right up, you can see these are health workers from the lower facilities at the hospitals. They were having a mentorship on care of small and sick newborns, and they had 2 weeks of mentorship and also clinical rounds where they were actually seeing the sick newborns and working. Some of them had actually never seen the cases, and some of them were testifying that actually the babies were dying in their hands, and yet they could save these babies. So we also trained health workers on the IPC and also introduced kangaroo mother care. And here, this is the physical environment. Some of the works that we have done, we broke walls, we created space for small sick newborns, the new special newborn care units, we provided equipment, we did the 5S in the units, but together working with the districts and the health facility staff and our partners, that was JICA and AFSI. In terms of enhancing respectful care, this is some of the makeups that was done by JICA in 8 hospitals in West Nile region. So we worked on the maternity and also created space for the small care or for the special newborn care units. So this enhances privacy. The health workers are excited that the environment has changed. They are better able to work in a convenient and clean environment. This is the washworks, and this washworks was dependent on the needs at the facility, and it's a comprehensive package. It's not just going and fixing a tap, but what does the facility need in order to provide quality of care? So, and it's based on the needs. At the community level, referral and access is one of the issues that we also addressed, and this is a transport voucher system that was very critical even in the time of COVID, and especially in areas where facilities are far from the communities, mothers are able to access services timely. Now, this is this is my last slide, and actually, what are the key things that we have seen over time? And many times we are challenged to move away from a project mode to a health system strengthening approach mode. Because many times when the project comes to an end and everything is left, okay, UNICEF is not supporting, UNFPA is not supporting, this partner is not supporting, RBF has closed, but have we addressed the systemic issues? And therefore, one of the areas that we have all discussed and the panelists have also shared is leadership and governance. In a region such as West Nile, many of the positions at the DHT positions are acting. Many of the people in these positions are acting. And therefore, maintaining some of the works that have already been started and the commitment towards delivering the quality of policies or decisions that we want to see is kind of curtailed, because these people are maybe sometimes they're junior staff and they're in active positions, so the commitment is not there. Then we also looked at the human resource management system. If we can have a human resource management system that actually works in terms of, because like, for example, I give an example of the special neonatal care units in the hospitals where we have established or strengthened. Human resource is such a big issue, where you train the health worker, you come back after 6 months, you find this health worker has been moved to another unit. So the rotation, how do we manage all this to ensure that the right staff remains in the right station of duty, so that our effort in building this capacity does not fall in the drain? Then we also looked at human infrastructure. Dr. Oliver has mentioned this, and equipment. And if we can have an inventory system which can monitor the equipment that we provide. For example, now we getting the biomedical engineers to go and fix the equipment. Sometimes we don't need to even buy the equipment, but do we have a system that can support the regional workshops? Because right now they're understaffed and overwhelmed and may lack even the spare parts to go and fix and traverse the whole region. Then if you can have an agile commodity and resource management system in place, a real-time inventory system, how does the hospital look at their medicines, the commodities, how do they track it? How do they monitor the availability? How do they monitor the stockouts? If we can get maybe an automated system that can help them do this in real time, that would help us. And then a mechanism for oversight on processes of care and a robust system to utilize clinical data, not just at health facility level, for the health facility level by the health facility level managers, but also program managers at district and national level. What, for example, when we're looking at MPDSR, our report for the last financial year shows that the reviews have gone up, and we are so happy. But has that translated into reduction of deaths? No, it has not, because we are not implementing the actions. Yeah, so if we can have a system that notifies different managers, a death has happened here, the review has happened here, and an automated system that quickly works, that would help us. Then my third last point is a referral system and communication. We have an interfacility referral using ambulances, but the mothers are dying because there's no proper communication system between facilities. This facility receives a mother late, she has died, and they have not reported back, and we need to enhance that. Then CRVS, birth and death registration. Right now, WHO has supported the trainings on ICD-11, and we look at this as an opportunity to develop system for viable community autopsy, where we shall look at the determinants of health that contribute to some of the bad outcomes that we are seeing. And lastly, I think this one has already been addressed by the RBF program, and we are so happy that the RBF program is happening, because when you go to the facilities, you are amazed. Yesterday I was in Kigumba Health Center 3, and the work that they are doing using RBF funds is amazing. So we are looking at this in terms of enhancing client-centered care with this funding, and I think Dr. JICA has already mentioned this. And we are so happy with the RBF program, and we hope that it can go on for quite a while. It will show us significant change. Lastly, I want to acknowledge our main funder, CEDA. All this work that we have shown you and we are doing in West Nile region is from money from CEDA. We acknowledge the support from the Ministry of Health. The departments have been so supportive in terms of taking forward our programs. The local governments, AFC and JPIGA, our partners, and other development partners in the region. We also recognize them because we work together in a coordinated platform. I want to thank you so much. Over to you, Dr. Sendiona.
Thank you,
this
thank you.
Brings me to the end of my presentation. Thank you.
Thank you. Let's give Dr. Grace an applause. Thank you very much for that very good presentation. You have a story to tell, definitely. You have just had just a bit of that story. And we appreciate the good work you are doing there. I understand what the Center for the Function in West Nile. That is remarkable. If you look at the district league table, Dr. Sarah is here. I think West Nile is well represented among the top 10, and they have been consistent doing well. We thank you very much for that good work and the support. We shall not give more details on what she has shared, since time is running out for us. We need to listen to our partners on the ground to get their views, and specifically here, we are looking at looking at strengthening and maintaining the gains made in quality improvement, interventions, and support amidst this pandemic. And Dr. Dissan is online. Chiraga is the Chief of Party for Rice North, actually. And we are giving you, Doctor, 10 minutes. You are the last discussant. Try to be as brief as you can and be focused on the points. Doctor, you're welcome.
Yes, thank you, Chair. Good afternoon, everybody. It's a privilege joining you all this afternoon. Rice North actually is a USAID contract managed by URC. I also want to take this opportunity to, on behalf of the organizers, to thank everyone who has put in the effort and resources to organize such a successful 7th National Healthcare Quality Improvement Conference. I don't have any slides, but I'll quickly talk through my points. I know time is not on our side. Now, in terms of strengthening and maintaining the gains made in quality improvement initiatives amidst the COVID-19 pandemic, as a country, over the last 5 years, we've implemented the Health Sector Development Plan, whose goal is to accelerate progress towards universal health coverage. Also, we've been working on a number of international initiatives, such as the Sustainable Development Goals. Now, through the leadership of the Minister of Health, in collaboration with development partners, the private sector, civil society organizations, and the community, we've made tremendous strides in ensuring provision of high quality services which contribute to attainment of good quality life and well-being at all levels of the healthcare system. And you can actually make reference to the recent annual health sector performance report to appreciate some of these gains. Now, all these achievements have been made possible with targeted quality improvement initiatives that have been implemented over the last couple of years, including the rollout of the revised consolidated guidelines for HIV prevention, care, and treatment. We have national QI initiatives on viral load suppression, elimination of mother-to-child transmission of HIV, child and adolescent clinical care, maternal, newborn, and child healthcare initiatives at health facilities. Now, obviously, we are all aware that since March 2020, Uganda, like the rest of the world, has faced the COVID-19 pandemic, which has placed a huge toll on individuals, families, and societies across the world. The health system faced unprecedented strain due to a surge of diagnostics and treatment of cases. And with the COVID-19 pandemic, several challenges have emerged, which have affected health service delivery. And some of these challenges have included, we've seen redirection and channeling of resources to avert the COVID-19 pandemic. And as a result, we are seeing reduced funding for other critical activities, including quality improvement initiatives. We are also seeing reallocation of health workers to support the COVID-19 response. And a lot of our health workers obviously have been infected, and this has affected the availability of human resources for health service delivery. Also, over the last year, we are seeing a reduction in utilization of health services with decline in hospital admissions by the public, largely because the community has been anxious about the risk of exposure while accessing these services, plus the lockdown and the impact many of our would-be beneficiaries could not access transport to access healthcare services. A number of indicators have fallen, including deliveries within health facilities, vaccine coverage for measles. We are also seeing the timeliness in terms of the reporting has significantly declined because of the COVID-19 pandemic. Now, with these deepened performances on a number of health indicators, there's need to strengthen our efforts to sustain the gains that we've made over the past few years, and also to improve the areas that have been impacted by the COVID-19 pandemic. So the question for us now is, how does the healthcare system respond to strengthen and maintain the gains we've made as a country with the QI initiatives amidst the COVID-19 pandemic? How do we keep the QI work going on? How can we improve service quality for COVID-19 response itself? And one critical area which has been highlighted by all the panelists is related to strong leadership across all levels. So we need to have continued strong partnership, leadership, and collaboration between the Ministry of Health, development partners, civil society organizations, and the communities in response to the new normal in the context of the COVID-19 pandemic. And this is really critical if we are to strengthen and sustain the gains that we've made over the last few years. So this will ensure that there's planning, there's mobilization of resources, and there's structured implementation of initiatives to address the key areas which have been largely affected since the advent of the pandemic. Also, because the healthcare system has been stretched with health providers having to be reallocated to respond to the COVID-19 pandemic, we need to increase the commitment of health providers and healthcare workers in the public and private sector who are working under difficult conditions in the context of this COVID-19 pandemic, especially in the hard to reach districts. And one way we can support them is by provision of personal protective equipment and other IPC materials. They need to be supported with training on infection prevention and control in COVID-19 management protocols and guidelines. We need to also come up with innovative work designs so that workers can work in shifts, but be available when called upon. We need to strengthen support supervision to ensure that there's maintenance of work ethics and also to maintain the productivity. We need to explore innovative service delivery approaches to reach the end users who may not be able to come to the facilities, possibly because of the fear of getting infected and the transport challenges. So things like community service delivery approaches, such as differentiated service delivery models of community drug distribution points, community client-led approaches of drug distribution, community outreaches, involvement of PLHIV networks in delivery of drugs need to be enhanced. We also need to improve the clinic efficiencies. It's really critical that we support reorganization of the patient flow within the health facilities to prevent crowding, to allow for social distancing, installation of hand washing facilities within different departments. We need to strengthen the triaging in all service delivery entry points to quickly identify suspected cases, and also to reduce the risk of spread within the health facilities. But critically, now more than ever, there's need to embrace digital medicine, telehealth, using the available platforms, including phones, SMS, applications such as Zoom, Google Meet. We've had different experiences from presenters over the last 3 days. There was one that was shared yesterday from Gulu Regional Referral Hospital, where they're actually using a lot of telecounseling to reach a number of their clients that need care and support. We also need to accelerate research, innovation, and knowledge sharing to develop medical countermeasures, including vaccines, therapeutics, diagnostics. We are now seeing some countries rolling out vaccines for COVID-19, and we need to start mobilizing the resources as well as preparing the supply chain for this. We also need to ensure that the vulnerable, especially during this time, do access services for both the diagnostics and the treatment. We need to strengthen and optimize health system capacity to respond to the rapid increase in caseload. And so finally, as I conclude, numerous gains have been made in CHUA initiatives to accelerate progress towards universal health coverage and progress in achieving international initiatives such as the SDGs. However, with the disruptive impact of COVID-19 pandemic due to the surge in demand for diagnostics and treatments, there's a risk in losing the gains with all the resources and efforts being diverted to the COVID-19 response. So there's need for continued leadership, partnership, and collaboration between the Ministry of Health, development partners, civil society organizations, and communities to strengthen our healthcare system, to have available, competent human resource, leverage on innovative service delivery approaches, maintain risk communication and community engagement, and focus on research. Thank you so much.
Give a hand clap to Disan. Right North has been a very big partner in the preparation of this conference. We want to appreciate them. They have given us substantial support to secure the venue, to do so many things. So thank you very much, but also we appreciate your contribution. Yeah, you can give a hand clap for that, really. Thank you so much. Let's, now, we have used a lot of time in the presentation, sort of discussion. I think next time should be different, really. So we shall take a few moments to get 1 or 2, 3, 4 reactions before we go to the closing ceremony. Allow me to recognize our Director General of Health Services, Dr. Henry Mwebesa, is with us. Doctor, you're welcome. He's one of the fathers of quality of care in the health sector, and the mother is also here at the other end. So we need to appreciate their being here with us. But members and those online, let's have, I think, about 10 minutes. People can react to what you have heard. It has been quite substantial from different speakers. Dr. Sarah was here on RBF, and the professor talked about the leadership. You heard about the supervision. You heard about MNCH implementation, court of care in Western Nile, and of course there's a lot going on also in Karamoja and other areas, and also the sustainability issues within COVID. It's a very important session, but we can get maybe 1 or 2, 3 reactions, and before we can move to the next part of the program. Anybody want to say something now? Can I get a hand or 2, 3? 1, 2, 3. 1, Benson, 1. Another hand? Online? Online there could be some issues. Benson, you can start. You tell us whom you want to address your issue to.
Thank you, the panelists. Mine goes to Professor Fred Sengoba. He discussed and tackled the leadership issue among the topics. And Chair, we missed a very important topic, which was focusing on the attitude change by the health workers. And I would wish to hear from Professor on how leadership can help us influence attitude change, of course, in a positive direction, considering that that is something that we are really grappling to deal with. Thank you.
Thank you very much. Any other hand in the house here? We are short of hands, it seems. So let's go online. There's a hand behind there. Please come on the microphone and say something to the panelists. They should not go without hearing from us.
Yes, I am Fontiano Korobe from Moroto. I have seen from about 3 presentations something about DHO's position, the issue of acting. And when we are talking about leadership, if leadership and governance is not really well supported at that level, we shall always continue having challenges in our districts. I've seen, for example, in the Moroto region, there are about 3 DHOs that are substantial. The rest are acting. Now, there is this issue of politics, which is also affecting the leadership and governance at district level. So I think the center needs to look into this so that maybe this position is either centralized, we give them more power so that the politicians do not over-disturb them as they deliver services. Thank you.
Thank you very much. People in acting positions, DHTs, the whole entire DHT is acting, especially the new districts. It's a challenge, and the politics is at play. I don't know who is going to give us a solution. Since the professor is here, he will give it a hint, but of course, Dr. Sarah can also make a comment on that. Can we get anything online? Anybody want to say something? Yes, please, come along. And introduce yourself, please, and then you ask the question.
Yes, good afternoon. I'm Nwagawa Peter. I work for USAID Rights EC. This question goes to Dr. JICA. We are aware that we have the DHIS2, and this churns out a lot of data. How possible is it to utilize data in DHIS2 and also in high risk to contribute to RBF outside the normal assessment that is done? Because I believe that these 2 systems have rich data that can actually contribute to the assessment of RBF and contribute to the indicators. I think this one is for the both of them. There is MOH has a U report and hotline. I think the dissemination has not been widely done because I think based on the resource constraints around client satisfaction, these are one of the low-hanging fruits that we can utilize. And I've also observed that we do not have the feedback mechanism. The information that goes through these two channels is not being relayed back to the community. And then, of course, the supervision data, this is to Professor Fred. We see a number of supervision being done by the central level, but we never have a forum for where to give out feedback. It only stops at the people that you have met. Yet actually, you find that various regions or various facilities have the same challenges and may benefit from that benefit. So how can we strengthen the relaying of supervision outcomes to the beneficiaries? Thank you.
Okay, thank you very much. I think if there's anything online or a hand, is there a hand? Before they, okay. Margaret, you're Margaret, I think, if I remember. And then somebody can summarize what's online. One or two issues. If it is a hand, you can give it a chance.
Thank you very much. My comment goes to Grace. She said that
Go near the microphone. Speak through the microphone.
I'm Margaret Narukenge from Rural Hospital. So my comment goes to Grace. She said that after training the health worker, she's transferred to another facility. We expect this health worker who has been trained to orient other health workers that even if he's transferred, the services keep on going. And where she has been transferred, you have transferred the skills. And the staff in that facility and the patient, they benefit on those skills. Thank you.
Okay, yeah, thank you. You are trained, you are transferred. You go to maybe another fertile ground and you produce more products. Maybe quickly we get responses. I have not had the online issues. Let's see, Dr. Sarah maybe quickly respond, and the professor, and then we appreciate it. And we shall hear from Grace and Olive, 2 minutes each, and of course Dithan. Then as you summarize and you conclude.
Yes, thank you very much, Chair. I'll start with the DHT status recruitment. Our current assessment shows that the entire DHT staffing level stands at about 64% as of last year. And that is a bit of improvement from the previous years where it was about 56%, 54%. So there has been some effort in recruitment, but we are aware of some challenges, which include inadequate wage bill for its local governments to facilitate the recruitment, in addition to the issues that the acting DHO Moroto raised. So it is still a big challenge, and we also know that when they are recruited, there are issues of retention which arise. And our recommendations for the last 3 or 4 GRMs has been re-centralizing the position, some of these management positions within the districts, including the DHOs, but that is a process that requires a lot of engagement, because that would be the current status we are operating within the Decentralization Act. So that would require this issue to be tabled before Parliament to see that that can take place. However, so that is ongoing, and I think even when you look at the current NDP3, which looks at addressing issues of having skilled, competent human resource at all levels, including in the service delivery area, under the Human Capital Development Program, one of the strategic shifts that was mentioned is re-centralization of the DHOs. So there is commitment to see if that can be done, as we also advocate for wage increment so that the positions can be filled up for these critical cadres. And for the utilization of the DHIS2 data for RBF assessment uses the existing data. However, currently it's largely manual. So the output indicators are all generated from our HMIS, and the DHTs do go to verify what the facilities have reported in the DHIS versus what is on their invoices. So we do utilize that, but we are working on digitalization of the entire RBF processes so that even the facilities do not have to submit manual or physical invoices, but all the assessments and everything is digitalized and can be accessed faster, because the manual process delays also the entire verification process. So we are working on that, but largely the indicators and the system validates what has been reported in the DHIS2 versus what is actually on the invoice that is submitted. Thank you.
Thank you. Thank you very much. Professor, 2 minutes.
Thank you, Chair. The question I think addressed to me, one was about attitude change for health work, especially what would be the role of leadership in that. Part of the answer, I think, is about modeling. We know that leadership is very much what they see rather than what you tell them to do. So many leaders, I think this is a challenge that if you are definitely, let's say, the director or the team leader, and you are shouting at patients, chances are your team also will do the same. But if you be the difference, chances are that people will follow you. So when you lead, you expect followership, but those who follow you should be led by example. That's one. But the other thing is also, as leaders, we need to take time and diagnose why are people actually having these attitudes. And many times these attitudes are also imposed on people. You'll know that human beings actually have wires which can cut. And part of the reasons why those wires cut, you may find that the leaders have influence in those areas, and they can influence people to actually be more able to be happy, to have less stress, to feel that they are actually belonging to the institution and what they do is valued. Some of those attributes come from leaders themselves, but also from feedback from community and the support systems. I always say that if you have a worker that is not going on leave, his sleep is interrupted every day because there is not enough recruitment. I worked in a hospital for about 6 months. I was the only doctor. And I can tell you, I went to the DHO and told him, you know, I want to go back home because I can't live like this. And I was near a refugee camp and there was fighting near Sudan. So every night you could actually be amputating a limb or removing a bullet. And I thought that in such a situation, you can't afford to be with your normal wires all cooled up. They may flare up sometimes. So I think we need to sit back and diagnose clearly what is the reason and be able to find lasting solutions. But clearly, individuals have a role, but leaders also have a role. Thank you. The other question, I think, has been answered. I think the challenge of feedback is very important. There's a lot of data going up and a lot of surveys that speak to national level needs. Many of these surveys do not lend themselves to what a district should do. It can participate in a survey. We do research. We also are culprits. We go to districts, collect data, and sometimes we don't actually organize district-specific feedback so that they can act on their own part. And I think this is a big issue. UNICEF also presentation was about this issue. How do we feedback how can people act on information? Simply said, if the acts that you need to respond to this data are within your control, then it's important that that data is sent back. If the acts are supposed to be that as a district or national or donor, then still give feedback and say, given that figure or that information, we have now changed XYZ to improve. So back and forth, I think, is very important. I think I'll stop here and appreciate all your effort and patience. Thank you.
Thank you very much, Professor, for that information you have shared. Olive, kindly, 2 minutes. Olive, are you there?
Yes, thank you,
Yes.
colleagues, and thank you, Chair, for this particular moment when we reflect on what finally we have said. I think for me it was important to appreciate that we work in one system which is interconnected. And for every piece one would like to do, if we look at supervision, I know that the ministry had such a system and a platform where all supervisors of the quarter would come back and say these were findings and these were the root causes, and they are portion now, follow up, who is going to do what and is responsible for this piece. So that you spend the next 3 months ensuring that that gap is filled, so that you are able to now report after 3 months to say, finally, we have managed to correct this. Otherwise, the supervision, mentoring, and the gaps we are trying to identify and filling, if they do not have a logical conclusion, it becomes difficult. And therefore, that feedback system at all levels need to be interconnected. And I think the Ministry of Health will see how to get back to this systematic approach from community, clinical, district, back to the national, to take on the roles and responsibilities it can do. But having said that, each level of care has a role, has a responsibility in ensuring quality. Moving from community accountability, transparency, to health facility, to district, back to nation, and backwards. That would be my contribution, and we need to cultivate that for things to happen. Each of us taking their chunk. Thanking you very much. Over to you, Chair.
Olive, for that submission. Thank you very much. Supervision is very important. Some of the things, your issues you have raised, are answered in the strategy. We hope we shall work all together to see that it's operationalized. Grace, 2 minutes. Grace?
Mine is about transfer and training and transfer of the staff. Now, I want to agree with the submission from the participant that sometimes the health workers are able to transfer this knowledge, but it's on rare occasions that they do this. Now, for the case that I want to cite is a special newborn care unit, where you have provided equipment, you have set up the place, and you have retrained the present staff on how to care for this sick small newborn. And this skill requires some time of training and development, to acquire that skill. So sometimes the health worker is moved to the OPD, the health worker is moved to the maternity, the health worker is moved to the family planning clinic, and leaving this unit abandoned and like a white elephant, and nobody's there to manage because they actually do not know how to use this equipment. So that means that from time to time, you need to come out from the external to train, keep on bringing mentors to train the different staff. We've gone to facilities where we have trained staff. We take staff out of the facility to a central place to train them on emergency obstetric care. When this staff goes back, there are no CMEs that are organized. So this goes back to leadership and governance. Do the leaders in the facility, are they able to organize such CME to ensure the transfer of knowledge? So what we think could be a solution for us is to develop a dashboard in the IRIS that can be able to give us real-time information on the changes in the staffing. And this will help the managers to also monitor which units or which units are staffed and which ones are understaffed, and which skills are lacking in a specific facility. And that's my contribution to the
much,
question
Grace.
from the participant. Thank you.
And we appreciate, of course, the support from UNICEF and the good work you have told us part of the story. I'm sure you shall get opportunity to get all the details. And the last Edison, you have anything you want to add, to comment from what you have submitted already?
And since the DG is around, mine is more of an appeal. We're looking at data from the sub-region, looking at the number of health workers who have contracted COVID-19. And I think by September 15th, we had close to 100 health workers who had contracted the coronavirus. Now, at the beginning of the pandemic, we had a lot of donor goodwill. So many partners came through, and we had some resources to support the response. Obviously, at this stage, there's an element of fatigue, and we are struggling to support not only the health workers, plus, of course, the community response. And even some of these border posts where partners were coming in to either recruit, place professionals, data assistants, that support is being weaned off. Also, us as Rice North actually received a generous contribution from USAID to support this response. Unfortunately, that funding ended. So it's something we need to be mindful of, the fact that we are seeing increased community transmission, that we need to remobilize the resources and support to support the region as well as the country. Then someone also mentioned, I think it was Miriam, DSDM being largely limited to HIV services. I think that's partly true, but obviously with the advent of COVID-19, it has forced us to rethink our strategies on how we can deliver these services closer to the beneficiaries. And we've used this same kind of platform to provide other services that the community might require. For example, if a mother came in with her child, she should be able to benefit, say, from immunization services. TB is also one area that we've exploited under the DSDM kind of platform. But I hear you. This should be an opportunity to bring on board other chronic illnesses like hypertension, etc. Thank you.
That's very critical. We have lost colleagues. People have got infected. There's stigma. People, when you health worker fall sick and you come back to do service, patients are running away in some facilities. So I think it's a big challenge on our hands. We need to see how we are going to overcome some of these issues. There are some issues which have come online, but I think they'll be answered online. I request for that because time is really not on our side. Thank you very much. The panelists, I think give them a very loud applause. Thank you much. Thank you so much, the audience. We appreciate your attending and the participation. And I think we have come to the end of this session. Would you like to hand over to the MC to take us to the next part of the program? Thank you very much.
Dr. Sarah, you'll be a constant, so you might not be, you won't leave. We will retain your seat, please. Let's give a round of applause to our panelists of this afternoon, and of course the moderator, Dr. Martin Sendiona. Thank you so much. Professor Sengova, it's been awesome. Thank you so much. Dr. Sarah, Dr. Dithan Chiraga, and of course, Dr. Olive Sentumbwe, and of course, Dr. Grace from UNICEF. Thank you so much. Now we are coming now to the last bit of the closing, and I'll request, I think Dr. Martin, you help to bring the DG. Okay, since the DG is very able to the podium, and maybe I will request you to bring Madam Tamara Nsubuganyombi to the podium also so that we conduct this closing. You this and in the middle. Yes. Yes, Dr. Martin, you're a gentleman, so. Yes. So as we are getting all the relevant persons on the podium for the closing, also want to appreciate our colleague, Director of Governance and Regulations, Dr. Joseph Okwari is online, so we can salute him. He's here with us in spirit. He was just unable to make it to this place. So as we observe the closing, usually the Director General wants to start with a word of prayer. But we prayed in the morning, but yes, he prays only in the morning. Okay, our guest of honor this afternoon, the Director General of Health Services, Dr. Henry Mwebesa, representing the Minister at this closure. The mission, USAID, CDC Director, which is represented by Madam Tamara Nsubuganyombi, Commissioner of Planning, Dr. Sarah JICA, our partners represented here, colleagues from the Ministry of Health, ladies and gentlemen, and all delegates out there, you are most welcome to this closing ceremony. And it's a pleasure to come to the end of the 7th Annual National Healthcare Quality Improvement Virtual Conference. This is the 7th, the only one of its kind this time round, because previously all of us would have been gathered in this hall. But this time round we are going to have it, we have had it virtually and we have succeeded. So we want to thank our partners and everybody who has worked tirelessly to make sure that we reach this far. At this juncture, allow me invite Madam Tamara Nsubuganyombi to give her remarks on behalf of CDC. You can use the, okay, she prefers here, no problem.
Thank you very much, MC. I hope I'm audible. Okay. The Honorable Minister of Health, Dr. Jane Ruth Acheng, represented by the Director General of Health Services, Dr. Henry Mwebesa, the keynote speaker from this morning, Professor Rhoda Wanyenze, the members of the Health Service Commission present, and the senior officials and technical officers from the Ministry of Health, health managers from the regional and district health institutions present, members of the academia, UN agency representatives, United States government colleagues present, ladies and gentlemen, all protocol observed. Good afternoon. I'm delighted to join you today as we officially close this 3-day National Quality Improvement Conference, now in its 7th year, and yet in many ways the first of its kind, using virtual platforms and social media to host a large number of participants. Congratulations to the Ministry of Health. Congratulations to the Ministry of Health for keeping the momentum despite the current challenges presented by the COVID-19 pandemic and for conducting this conference in the safest way possible. CDC has been supporting the Uganda Ministry of Health in addressing the country's health challenges for close to 30 years now, contributing close to $2 billion US dollars to the health of Ugandans. While the bulk of our programs in Uganda support the HIV/AIDS response with funding from the US President's Emergency Plan for AIDS Relief, or PEPFAR, we also support prevention and control of malaria, TB and other infectious diseases, emergency and outbreak response, maternal and child health programs, training of health professionals, and overall health system strengthening. which have been core to our discussions over the past 3 days. No matter what the public health issue is, our action always centers on people, science, systems, and response. That is why, on behalf of the CDC's country director, who regrets not being able to join us personally today, I'm delighted to be here as we close the 7th edition of this conference. The theme, client-centered quality of care to ensure patient and health service provider safety through evidence-based practices, could not have been more appropriate, especially in light of the COVID-19 pandemic, which has reminded us of the sacrifices our healthcare workers make every day in the line of duty. Safety for both the patient and the healthcare provider is critical. Whether you are an epidemiologist, a clinician, a counselor, a nurse, or otherwise. I would like for us to take a moment of silence in respect for the colleagues we have lost to this pandemic. And as a sobering reminder that we need to redouble our efforts to prioritize healthcare worker safety. Thank you. The US government is passionate about the public health research and innovation and translating it into public health programs that achieve impact. The range of topics addressed during this conference, from efforts to minimize health workers' absenteeism, engaging community health workers for improved service delivery, waste management, increased access to HIV and TB services, better neonatal care for better outcomes, and general maternal and child health programs, to ensuring quality post-surgical care, reduction of hospital-acquired infections, to positive health worker attitude change, the role of leadership and engagement of the private sector. Speak to Uganda's commitment to embracing a culture of continuous learning and quality improvement across the health sector. I am especially happy to see the contribution of our USG partners to many of these abstracts and presentations, as it highlights that our investments are demonstrating desired impact. My only ask today is that we put into practice what we have shared and ensure patient and healthcare provider safety, especially in difficult times such as these. As an example, I would like to remind you of the presentation on expenditure reduction using alcohol-based hand sanitizer at Kabale Regional Referral Hospital during the COVID-19 pandemic. In light of these findings, CDC directed additional resources through our partner IDI to work with other facilities to produce alcohol-based hand sanitizers in order to effectively and efficiently improve facility hygiene practices. Furthermore, the health facility quality assessment program that was launched by the Honorable Minister of Health on day one of the conference will help us to assess and monitor the quality of care provided in conformity with set service standards. This tool allows us to hold ourselves accountable to the people that we serve, enabling us to respond to the increasing need for quality-driven, client-centered healthcare. Together with other US government agencies, we are committed to supporting the Ministry of Health to roll out this tool through the partnerships we have with the regional referral hospitals, designed to strengthening leadership and oversight to public health programs within their catchment areas. As we celebrate our milestones, we need to especially review our gaps and challenges if we are to prevent morbidity, mortality, and suffering for both our patients and health service providers. During this conference, we have asked pertinent questions, shared experiences, disseminated evidence, and explored opportunities that are critical to quality and safety in healthcare settings. Let us now act. Considering the diversity of participants here, it's obvious, here and online, of course, it's obvious that this meeting brought partnerships and new solutions to life. The US government works side by side with ministries of health, community organizations, civil society, faith-based organizations, and the private sector organizations, local government, local and international implementing partners to ensure sustainable knowledge sharing. Partnerships may seem like the last block of the Sustainable Development Goals, but they mean everything. We are here together to make the lives and the fights of fallen comrades worthy of celebrating. As we share experiences and best practices, let us renew our commitment to improved safety in our health settings. As I conclude, CDC and the US government commend the Ministry of Health and partners that were involved in organizing and participating in this conference. May we translate the recommendations made here into better care to improve safety for our patients as well as our healthcare providers. Thank you very much.
Another round of applause to the statement from the CDC Director, delivered by Madame Tamara Nsobuga-Nyombi. Thank you so much, and for making it here to be with us. Our guest of honor, because we are now doing things scientifically, there is a task which you wanted to perform. Normally you have been performing it physically and handing over some appreciation, but before the Commissioner Sarah invites you to close the function, you allow us to just read the persons. They will be going there. Madam Josephine, I think you will be set there to pick the certificate. They will just wave to you as a sign of appreciation, like as if, like in the elections, you just wave to the voters. So you just wave to them. So the list begins by the organizers. So when I read your name, you go to that table and pick the certificate from Josephine, who's already putting on a glove to make sure that we observe the SOPs. And please, you keep distance when you reach there. So Dr. Martin Sendiona, so do it very fast. I'll read it. We clap for him and, yeah. Oh. Yeah, okay, yeah, you. Yeah, the ladies will wave from here, okay. Then Dr. Agre Batesachi. Good. Dr. Kakara Mwisho Alex, who is the co-chair for the conference, has done a great job to steer us up to now. Dr. Albert Kadama, in absentia, we just clap for him. Madame Claire Simwe. Yes, as she comes, Dr. Tumwesije Tuhezine Benson. Tuhezine, yeah, sorry. Dr. Munanura Tuliasima. I don't know if he's around. Dr. Christine Nakaima. Yeah, we clap, we shouldn't tire. Madame Barbara Komujuni. Mr. Julius Sendiwara. Julius. Then also Dr. Julius Amumpe is not around, but we recognize him. Dr. Juliet Tumwikirize. I saw Juliet around, okay. Dr. Elizabeth Namagala. Madame Agnes Nagai. She's outside there. Okay. She has done a good job behind the scenes, which Professor Sengova talked about. There are those people behind who never feature in front, but are doing a great job. Miss Josephine Coney. Okay, you appreciate yourself. The DG will just, she's the one. Madame Juliana Nabuire. Dr. Lawino Ann. Let's try to move very fast. Mr. Moses Chamacha Bwambale. Madame Susan Nakawungu. Miss Joy Kemgisha. Miss Beatrice Mugavirwe. Okay, I'm very fast. Okay. The DG wants to take in eye, okay? Agnes Ndagaya, I called you and you are not here, okay? Madam Beatrice, okay, thank you. Dr. Betty Atai, she was around. Yes. So the next one is Dr. Dithan Chiraga, who will receive it virtually. He's online, so we can clap for him. Since he's listening, has been appreciated. Madam Evelyn Akelo. And then Mr. Stephen Kaliesubula. Yes, thank you. Now our guest of honor, we had also a team of handling the virtual technicians who have made sure that they are now Grant Katurebe, Grant Katurebe, please. Davis Atwine, they are young men, they can move very fast. Ian Baker Muhirwe, please. Then the organization Land Production Limited, because they are the ones who are in charge. Then Senawiya Shafiq and Wanguzi Shadrach. So that's the team. DG, we are also interested in having a very good report. So we also assembled a team as rapporteurs. And among the rapporteurs, we have Belinda Tumushabe. We have Flavia Mbekeka, Linda Kani. Then we have Wilfred Soyekwo. Then Joshua Semfuka. Alfat Muyinga. And Jennifer Bachara. Then, of course, to make sure that over these 3 days, everybody was well documented, received, ushered in. We had a team of ushers. We have Nakato Mary, Ziwa Jimmy. I don't know, maybe they were outside at the desk. Akampa Ann, Odong Mark Anthony, and Mukwana Kenneth. So that one will represent. And guest of honor, social distance. And guest of honor, the last group has been a team of the program directors who have made sure that everything moves very well on the timetable, and people are mobilized and are made happy, and their stay has been worthwhile. And we have 2 members there. My colleague Herbert Nsereko and myself, Tabreba Chaita Basaja Tevadiva. Thank you so much, our guest of honor, for accepting to do that noble cause. At this juncture, ladies and gentlemen, and fellow delegates here present and online, allow me invite our commissioner in charge of planning, finance, and policy, Dr. Sarah Vyachika, to invite our guest of honor to close the 7th Annual National Healthcare Quality Improvement Virtual Conference. You were told that she's the mother. This is the father then of this conference. So this is the 7th. So we are privileged, Dr. Sarah.
Yes, thank you, Master of Ceremonies. I'm sure all of you have been waiting for this minute. But before I invite the guest of honor to officially close, I'd like to first of all congratulate you all who have been able to organize such a very successful conference amidst the challenges. So I think this is what you have done shows that amidst all the challenges, we should continue with service delivery. And therefore, congratulations to you all, and we hope that the recommendations from this conference will be shared so that we can continue with the goal of improving service delivery. Congratulations. So now I take the honor to invite our chief guest. We are supposed to be having the Honorable Minister, but she is here in the person of our Director General, Dr. Henry Mwebesa. You are welcome to officially close this conference. Thank you.
Thank you very much, Sarah. Let me start with a late one, a joke. You know, these days, the other day, we were lucky we had the minister here, and she opened our conference. It was real big luck, because during this period, if you write any ministry looking for a minister, the best you will get is a PS, if you are lucky. If you are also lucky, you can get a director, but usually it will end up at a certain level. So because of that, and our ministers not being around, this morning I've been running from hotel to hotel. I started from Africana Hotel, where I participated in a meeting. Now, it has both advantages and disadvantages. The advantage is that you are going as a minister and you are welcomed as a minister. So you take all the packages. Normally, yesterday I got a good packer somewhere. You take all the package of the minister and you don't declare it when you go back, because that's yours. But the disadvantage, let me tell you my story of today. I went to Africana immediately after finishing. I had to run to Munyonyo to make a comment, a statement on behalf of the minister. So I ran away from Africana when they were going for break tea. So I missed it there. I reached Munyonyo when they had finished break tea. So I had to join in and continue with the session. Because they were running late, I had to run here. So they needed to do their closing and in order to go for lunch. So I was too early for lunch. I had to leave without lunch. Now I rushed here. When I reached here, the lunch is finished. So at this time I had to rebel, and I told Benson that without lunch I'm not doing anything here. So courtesy of Benson, and courtesy of my fighting, I had to get lunch. But otherwise, I would have continued from morning up to supper. That is the later part, but I thought I would share with you that joke, because it happens that often. So, as I said, I'm here to represent the minister, and I have the minister's speech. And for that matter, I read the minister's speech as it was given to me. And like a disciplined civil servant, I'll try to keep to her text. But also as a DG, I cannot just read the minister's speech without mentioning somewhere my own words. Along the way, maybe indisciplined a bit and interject and put in a few of my own words. And one of the disadvantages as ministers, they always have long protocols. And since this is her speech, I have to observe it, so allow me to observe the protocol. The mission director, USAID, the CDC country director, I think represented by my sister here. UN agencies represented here. Senior colleagues from the Ministry of Health, distinguished members of the academia. I recognize the presence of our senior colleague, Professor Sengova Freddy. District health officers, I think most of them are online. implementing partners, those here and those in the online, registrars of all health professional councils, representatives of other ministries, departments, and agencies, all staff of Ministry of Health, ladies and gentlemen. Good afternoon, ladies and gentlemen. Like Sarah said, I also want to start by congratulating you all for making it to the end of this important conference. It has been the whole 3 days of sharing what we have done and what we have achieved in the previous year, and the interest on improving the quality of health services in our facilities. As you all know, we do this every year. So in particular in this meeting, we have been following on one of the improvements that have taken place since our last meeting that we had last year. I have no doubt that a lot has been achieved and a lot has been learned. And based on the lessons learned and the changes that have been made towards improving quality of care, there will be a lot of client satisfaction for most of our clients. And this usually is our target, to make sure that our clients are satisfied and they leave our health facilities, they leave our districts, and they leave all our facilities satisfied with the services that we provide. My colleague talked a lot about this conference. I'll just highlight a few by trying to avoid repetition of what Honorable Minister of PHC talked about at the opening ceremony. But first of all, I also want to add my voice. Thank you for responding to our call to participate in this 7th National Annual Quality Improvement Conference 2020. Particularly, I want to thank in a special way all those who made effort to submit abstracts, but importantly, those abstracts which were considered and have been shared in this conference. And I really want to congratulate you all for that and thank you so much. Thank you. I'm told 294 abstracts were submitted and a total of 85 were selected, 56 as oral presentations and 30 as poster presentations. I'm also informed that the conference has been a success despite the COVID-19 pandemic situation. By the way, I need to add my voice. I think I said it the other time about the way we have adhered to SOPs in this meeting is very impressive, and I want to congratulate the organizers. In one of the meetings I went to, I will not tell you which, it was my first complaint. I said, I'm here to make a presentation, but I'm not very comfortable with the social distancing. But here, the SOPs were being really adhered very strictly. In terms of social distancing, sanitizing, temperature scanning, even in the dining, it was really very, very, very impressive. And I want to commend this hotel. It's my first time here, incidentally, but I really want to commend this hotel for observing the SOPs. So although we did not do it the usual way, we did it virtually, and that's the new norm these days, but we are aware that many people participated, many people joined online, and many people contributed, listened in, but also contributed. To us, this is a sign that quality improvement initiative is getting entrenched in Uganda in many different ways, and I have no doubt that we are on the road for quality improvement integration, institutionalization, and sustainability. Let me thank once again the keynote speakers. I want to take this opportunity to thank our keynote speakers, Dr. Carlos Javia, Dr. Carlos Javia from URC Washington, who actually made the keynote speech on the first day. I remember it was 10 o'clock here, 10:30. I believe it was around 4 a.m. or something like that in Washington. So we kept Carlos waiting, and of course we never also kept time, but I really want to congratulate him and thank him for keeping awake for the sake of quality. Professor Rhoda Wanyenza, I'm told made also a very, very good presentation as a keynote speaker. We really thank her and congratulate her. We also thank and congratulate Professor Handa Yujiro for a very good presentation that he made today. And Professor Handa is not making this presentation for the first time. Actually, I think he has made it. This is the third time in a row. So we really appreciate, and we don't take that for granted. Whoever can send our acknowledgement, our appreciation. If JICA is around, please pass our special regards to Professor Handa. And say it is from the minister, don't say it's from Mwebesa. Because I'm reading the minister's speech. So this special appreciation is from the minister herself. I also want to thank the panelists and the chairs of the sessions for a job very well done. We really appreciate you committed time, and you did a very good job. Thank you very much. Having gone through all this, having spent 3 days here, where we have spent a lot of our time, we've spent a lot of our resources, our partners who have put in all the resources, the question now is, how do we keep what has been achieved, and how do we do better next time? That should be the bigger question at the back of our minds, that what have we achieved after this workshop? The lessons learned, how are we translating them into our daily activities in the areas where we work? How does it translate to improved quality service delivery in our facilities? How does it translate to better patient care and more client satisfaction? Then the issue of the district leadership has also been emphasized in this meeting, and I want to add my voice that we need to strengthen leadership in the districts, especially for our lower level health facilities, even the hospitals. As you heard in many of the presentations, the issue of leadership needs to be emphasized and is very key in improving the quality of health service delivery. Here, let me add my own comment. I want to emphasize the issue of leadership, especially the DHT leadership, and with respect to the health center force. We've been going around the country, and we've been mentioning this in many places. We find a lot of dissatisfaction with the quality or the work being done by doctors at health center force. We notice that the main reason really why we have doctors at health center force is to ensure that we have cesarean sections, we have blood transfusions at those levels in order to reduce on maternal mortality. But what we notice is that health center force are just pushing patients to the hospitals, to the regional referral hospitals, and those patients who come to the regional referral hospitals deliver normally. Actually, in one place we are told 88% of all the referrals from health center 3s and health center 4s reach the regional referral hospital and delivered normally. So that means the facilities down there are not doing their work. And it gets worse over weekends. From Friday, no health center 4 does any cesarean section up to Monday. So we notice that those doctors actually do not work over the weekends. And even between Monday and Friday, many of them are just involved in management activities. The reason why we got doctors at health center 4s is mainly for working on the issue of emergency obstetric care, cesarean section, and blood transfusion. So if you are there and you are just signing vouchers and you are just making a work plan for requisition of money, then you are not helping us as a doctor in a health center 4. I think this is a component of quality, and I wanted to emphasize it, because if you are losing mothers at health center 4s, or if you are referring them late and they arrive at a regional referral hospital late, when the child is tired and you are getting fresh stillbirth, when the mother is tired, you have cord prolapse, you have uterine ruptures, then we cannot be talking about quality. And for us, really, we think this is a very big gap in terms of quality, and I thought I should emphasize it in this meeting. The theme of the conference has been client-centered quality of care to ensure patient safety and provider safety through evidence-based practices. The theme brings out two main issues, namely the safety of the patients and the safety of the provider. And this is really very, very important. When it comes, before I leave the other issue, DHOs, I hope they are listening in. Starting this financial year, we expect all DHOs to evaluate the performance of their health center 4 doctors. And the performance of the evaluation of their performance will be based on the number of cesarean sections you have carried out and the number of special clinics you have conducted. And that will be one of the methods of assessment of their performance, and we shall be receiving that. Since we have also IPs here, I want to make a comment to the IPs. If you are an IP in a district, Rates East, Rates North, Rates Acholi, and your health center focal staff are not doing cesarean sections, and they have a theater and they have what? Also, I don't think you'll be very proud as if you are achieving your objectives. So we are also tasking the IPs in your area to make sure that your health center fours are carrying out cesarean sections. Your health center fours have fridges, because even you can buy a fridge for a health center for. A fridge for blood is about 5-6 million, and as an IP, really that's not too much to ask for you to facilitate. Also, delivery sets and labs, the functionality of the laboratories. We would request that partners take keen interest in this. I know USAID and CDC, you have interest in labs, but we really request that you take that as your priority. So, I had reached on the issue of the patient safety. Of course, in terms of quality, which is the theme of this meeting, has been the theme. Patient safety is very key in terms of when we talk about infection prevention and control, especially in our facilities. We don't want patients to come in our facilities and get other conditions which they didn't even come with. We have to look on issues of sepsis within our health facilities and other infections. And you may need to do, as health facilities, to do some studies on issues, let's say, of sepsis acquired within your health facilities. Then on the issue, the second issue of safety, which is now the provider, we really want to emphasize the importance of the safety of the health workers. In terms of infections also, we have to make sure that our health workers don't get infections. Also the issue of stress, I think I found Professor talking about it, and I thought that would be another very good example. Sometimes work overload leads to stress, and therefore less safety for our patients, our health workers. Then like those who have x-rays, you know, you find how our staff are not protected and they are getting radiations. Sometimes Atomic Energy Council comes and closes us and we start quarreling and making noise, but they are doing that really in our own interest for the safety of our patients. So this issue of safety for the patients, the safety of our health workers must be emphasized, and we must continue to emphasize it. And I hope we came up with good recommendations. I was shown the Secretariat. Secretariat, from these presentations, you must have picked good recommendations that should be adopted to emphasize that. The second key issue from our theme was client-centered care. The message here is that we cannot be effective in achieving the desired outcomes of care without actively involving the patients themselves. Now, the role of patient in management of their own conditions is very, very important and needs to be emphasized. I know in the private sector they try a bit, but in our public sector, we need to give time to our patients when they come in to discuss with them, to consult with them about their own management. And sometimes the way even we interact with them, the way we explain, the way we raise issues with them is part and parcel of the management. So not just a question of getting Coartem, Panado, and go. You need also to discuss with them a lot more than that. And it is very important for our own input. As I said, I know that private sector tries and the PNFP, but on the part of government, this is an area we need to emphasize a lot. But also sometimes the private sector can also be a bit tricky. Recently, I went to one of the dental facilities in this city here. Now, when I reached there, normally when I reach, I don't put my name. I put my names, but I don't put my title. I just say Mwevesa, occupation, I left blank. I don't say I'm a doctor because I don't want people to pretend to be too good because they know who I am. And as I had asked for a particular doctor that I wanted. I even didn't know he didn't know me. So when they came, I'm taking a lot of your time, but this is good experience to learn. You know, sometimes it's better to learn from what you have seen physically than things reading in the paper. So they first send somebody who takes my x-ray of the jaw and the what, and did very well. I think he was a technician. He explained his name and told me why, and then took the picture and then started explaining to me what was happening. I was very impressed and very happy. I even remember his names. So now he says, now the doctor is coming to remove your tooth because that one is spoiled, cannot go continue. I said, no problem, I think I was expecting this. Now the big doctor comes, I'm lying on the table, then the man arrives and starts, I'm going to put a retraction. Starts putting a retraction in my mouth. He doesn't even tell me who he is. He doesn't even explain anything. So I said, okay, this is it now. What do I do? So the man enters my mouth, pulls out his teeth. The tooth was one, throws it there. Then he was very quick to tell me that I needed to come back again for removing of another tooth. He suspects is also coming up, I believe, for making his money. And then next appointment is in 2 weeks' time. I said, thank you very much, doctor. I left. But I don't think, in my assessment, if I was to rank him between 1 to 10, I'm usually very generous, actually, even when you meet me in an interview. I'm not very bad. I will give him maybe 5. But some serious people, like some friends of mine, would have given him 3 or 2. But he did the tooth, he removed the tooth very well. I didn't get any problem thereafter. Technically, I think he did well. But interpersonal relationship involving me did not, I think, did not impress, in other words. And I can assure you I have not gone back yet for my second appointment. I'm not sure if I'm about to go back, but that's what it means. So what I'm trying to say here, let's try to, and really I don't think I needed much. Come introduce himself and say, oh, I'm Dr. Mwevesa. I understand when you made an appointment, you specifically requested that I be the one to work on you. It seems it's your first time to be here, but you are welcome. I think it is a nice place for you to be. You know, you need also to encourage me, and make sure that I feel at home. But, and that's what we need also in our private health facilities. And it is worse with those rural. If my mother came and you really talked to her nicely, even introduced yourself, greeted her, told her, oh, old woman, I can see you are getting tired, your diabetes is not very well controlled, what have you been on, and the like. Interact with her. What do you think? What do you think about your tablets you've been taking? Are you okay with the treatment? I think she'll be very excited. So I think that's enough of my stories now. Let's conclude. Finally, ladies and gentlemen, I wish to recognize the players who have strongly supported the quality improvement initiative in this country. And here I'll mention a few, specifically I'm mentioning, because I don't want to be misunderstood, that I recognized only a few partners. This is specifically with respect to quality improvement interventions in this country. I want to recognize PEPFAR, USAID, and CDC, who together have supported QI implementation through their IPs. JICA, who have supported implementation of 5S that later became an integral part of QI implementation. University Research Council, who has supported QI implementation since 2004 through their IPs, initially as QAP, healthcare improvement, assist, and now the number of rights in this country. All the IPs who have worked with us and provided resources and technical support to support QI, we are very grateful. And then I want to thank in a special way our Department of Standards, Compliance, Accreditation, and Patient Protection, SCAP. It is a mouthful. We used to know it as Quality Assurance, but now they have that long name. But I really want to thank you so much. The Acting Commissioner, Martin, thank you very much. And thank you for organizing this meeting amid these difficult times. I also want to appreciate your director, Dr. Okware, who has been here. and he did a very good job. I want to conclude by reminding ourselves that much as we made impressive progress, we are not yet there, and a lot of work is yet to be done. Therefore, more effort is needed, particularly in efficiency and effectiveness in use of resources. I want to see a mindset change for commitment to work, more compliance to standards and guidelines, and an increase in focused client safety and client satisfaction. Last but not least, I want to take the advantage of this time to inform ourselves that we must jealously keep peace in our beloved country. In particular, during these election campaigns, we should tell our people to stop the excitement. The biggest challenge we are having now, if you look at the statistics of COVID, we went very well up to April. We are still having around 100 per month. April we started 400. May we were around 432. But from August, when we started with those primaries, stories of primaries, we all of a sudden shot for the first time, we shot to over 3,000 in a month. Then in September, we struck 5,000. November, we've been in 7,000 per month. I mean, really, we are just killing ourselves. When you see what is happening on the streets, just the excitement, people get from there. And you know the problem with that? People go there. You know where we have reached now, really, it is a question of protecting yourself. You have to do your best to protect yourself. But the problem we are having now, especially for you people here, are our support staff. Our support staff are a big problem. First of all, they travel by public means. Secondly, they are in crowded environment where they sleep. If you see, every week I almost get reports from cabinet being tested. Many of their drivers, the bosses are okay. Their drivers and bodyguards are most of them sick. That is a problem of what? The crowding where they stay, the public means where they pass, and most of the areas where they are. Even when you go in ministries, most of the tests which have been done, the biggest number of patients or sick are support staff because of the environment and what? The crowding, especially in public. So, for you now, I have to tell you, you have to keep testing your drivers. And even these drivers of ours have habits of going home every weekend. If they can reduce, if one was traveling, because they stay in Kampala and somewhere, but then they travel up country in buses and whatnot. So normally, they travel a lot, and that causes or exposes them also to very, very high risks. So we need to advise them to reduce on unnecessary travels. So that is very important for us, because you'll try your best. You'll try your best to keep safe. But you cannot be 100%. If you look at your driver, is more with you than even your children at home. So you can have a sleep. You can pull down a thing and to drink water in a car was drink. And you are with the man in your car. Your support staff in the office is the one who brings in documents. Like I imagine how many times my office attendant comes to my office bringing documents per day. I think they have more interaction with us than even our own family members. So at times it can be very difficult to avoid getting problem from those support staff of ours. So we need to be very careful to tell them to avoid risking themselves. And these ones who are jumping up and down with the politics are even a bigger problem for us. Because as you can see now, we are talking of, now we have started 500 cases per day. By December, mid-December, we're going to be in 1,000. And that one I cannot pretend. We are going to reach it. 1,000 per day. You saw we jumped from 10,000 in August. Within 2 months, we had hit over 20,000. So the doubling numbers is moving very fast. So we really need to be very careful. So I sorry I took a lot of time about it, but I see a big problem unless we get somebody, maybe the religious leaders and the cultural leaders, because now even they are not listening to the political leaders because they are now divided over politics. But maybe the cultural leaders, the religious leaders should help to tell people to calm down and stay put and protect themselves and protect their families as well, and even protect we who work with them. So, ladies and gentlemen, it is now my pleasure to declare this 7th National Health Sector Quality Improvement Conference closed for God and my country.
Let's give another round of applause to our guest of honor. So we can't repeat what he has said. Thank you so much, because there were also other words of wisdom and guidance to stay safe. As you were mentioning, information was trickling in. One of our Muslim cleric, Sheikh Nuh Muzata, has also passed on in Ilai Rajhun. So it's no longer, so it's happening everywhere. So we need to be alert. But nonetheless, we just pray for his soul so that Allah may pardon him where he went wrong. So our guest of honor, we are going to have the national anthem. We shall stand up. Then the last thing we shall do is just to have a group photograph here. And our online delegates, you also activate your videos so that we have a closing photograph, the virtual photograph, and the physical photograph. So can we be upstanding for the national anthem? One stanza. So I'll request Dr. Martin, you know how to usher in the people on the high table. So parade them there. So we shall respect social distance, definitely. Just they stand there like we did on day one. Okay, so in order to fit in, where are the ushers? We can have some seats for the front line, then others will stand in. Let's do it since we are to save time. And then our online delegates, just activate. Online delegates, activate your videos. Thank you so much for being part of this 7th annual conference. Hey, well, these ones will stay behind. Okay. All right. Okay, we can. I want to thank everybody who has been part of this function. My co-program director, Herbert Nsereko. You can thank the members. Thank you so much.
Thank you very much, Mr. Table. I'd like to further echo Mr. Table, and thank you very much, our ushers, the organizing committee, our IT team, our delegates online, the virtual delegates, the delegates here. Your presence here has been really something to us and means a lot to us. And I'm very sure that what we have shared here is going to help and hold value to our next year health service delivery. Thank you very much, and have a blessed journey. Adios.